Hey everybody, welcome to Regulatory Joe. I'm Joe Boyle, president of ClearFile, and today I'm pleased to introduce our latest guest, Will Tesch, CEO and founder of TESCHGlobal and HealthLX. Will, great to have you here. Tell us a little bit about TESCHGlobal, HealthLX, and Coco.
Yeah. So thanks, Joe, for letting me be on the podcast. I always like getting out and sharing kind of our journey with people and some of the insights that we bring to the industry. Well, first things first, I own two companies, started them both from nothing. TESCHGlobal is a professional services firm focused heavily on healthcare use cases, but we do a lot of different work across the different vertical markets. A lot of fire experience in the TG team. And HealthLX is my software platform. We built an interoperability platform that's been accepted in the market. It's pretty exciting. It's a fun journey to be on. We have a unique proposition that a few others, or I'm not so sure anybody does what we do in terms of our platform. But we're very appealing to health plans that want to just find a solution, implement it quickly, and they leverage our teams.
Thank you, Will. I think the background and history is quite impressive, starting a company, but not just any company, but with the complexities that interoperability does pose, specifically modernizing this effort for health plans. Can you tell us exactly what is interoperability?
Our view of interoperability, at least in terms of how the country's accepted it, we've got the transport pretty much figured out. What we haven't figured out, and I'll point to different data points on this call, are the semantic accuracy of what we're sharing. So if you and I can't talk to each other right now, and you don't understand exactly what I'm saying, we have a breakdown, right? That's kind of what's happening in healthcare, and has been happening that way for some time. But there's a lot of different domains: healthcare domain, transportation, logistics domain, supply chain domain. All of them have to make sure they talk to each other accurately. And the difference in healthcare is there's a lot of impact if it's not done correct, right? So we all get nervous about that reality, but it sometimes doesn't trump the importance of actually getting real work done. I shouldn't say it doesn't trump. It's just crucially required to make sure we're really accurate in what we say and what we're hearing, right? In fact, I didn't touch on Coco, but that's what the whole point of Coco is. So we open sourced our IP after having multiple implementations of CMS compliance, 9115 in particular. We took our production canonical, we made it available to the industry in order to have semantic clarity. That's a huge deal. Nobody's done that. And we did intentionally because we believe it's critical for all of us to adhere to some type of semantic reference that can be made accurate for all of us.
I think honestly, so what you're laying out here is a couple key points. And when we talk about problem points that health plans are facing, you talked about literacy. So making sure communication points are clear. And even my line of work with CMS and in the exchange businesses, we try to keep things on a third grade reading level because of the complex work that we do today. When you talk about APIs and opening up FHIR on a more enterprise level, we're seeing health plans, not just with interoperability, but any technology, bringing it to one single source to the best of their ability, not using multiple systems for multiple functions. So if you could touch a little bit more about on maybe some of the key friction points that you're seeing in with integrating with health plans, or what health plans are maybe looking forward to optimizing in 2026 for the next plan year.
Yeah, that's a really good segue. There's a myriad of different types of health plans, but also sizes of health plans, right? Some of which might be on a different maturity curve. There might be some jumbo plans that are really backwards in terms of their ability to have a single source of truth or a reference point for a single source of truth. I would argue the smaller plans that are perhaps less complex have the same issues, but their need to fill those issues, they can't staff up an IT team big enough to solve for those. So I think they become more of a buy best of breed option as opposed to building your own, right? That's one angle I think that's relevant enough to bring up. So that means the friction points might be different. We've been doing enterprise integration across vertical markets for 20 years. And one thing that we continue to see is the investments that are made by best of breed products, which is prolific in healthcare, right? Those assets, they can't be easily replaced. They have to be integrated with, right? So we leverage concepts like API orchestration, a canonical to support various types of how you would do that interoperability. And anyways, we've got all these years of experience, and we think, in our view, the canonical is really important for the industry. Doesn't matter who uses it, a health plan, a jumbo, I hope, or a smaller plan, or a vendor that's doing implementation work across the different fire vendors. There's a lot of fire vendors out there. But ultimately, everybody has to have the same data understood the right way. And it was substantiated most recently by a FlexBus State of the Industry report, where they identified the health of our compliance across the country. It was a really well done report. We like the team over there at FlexBus because they're looking across the ecosystem of health plans, kind of holding our feet to the fire to some degree too. Like who's working better, who's not working so well. That's really relevant when it comes to semantic accuracy.
Oh, for sure. A simple fact that you've made your IP and your canonicals public, or even backed your brand with CMS. What makes your schema different than any of your competitors or other folks doing this in this industry today?
Yeah, that's a great question, and one that I could spend the rest of the hour talking about, but we won't do that. When we talk standards in healthcare community around CMS, these standards started in 2018. Now, the regs didn't go into effect till 2020, but the Da Vinci Group, which I would argue started the concept of value-based care. I think everybody in my community at least agrees to that. So we were starting on the regs, trying to get agreement from a process perspective between the plans and providers back in 2018 all the way until the regs came out. And then they were kind of amped up and everybody started working toward these FHIR constructs that were going to be required for 9115. So, okay, there's a lot of learning that went on. There's roughly 12 IGs right now required to be understood clearly in order for the 9115 to be turned on and considered acceptable. Now think about that. Each of those IGs has its own maturity curve. In fact, it has its own group of people that make up that particular subset inside the Da Vinci Project. It's a lot of confusion if you ask me, right? So what have we done by way of offering a canonical? We've actually created a production stable, understood, meets all the compliance needs. Having studied the IGs like we have, we believe this is a production example that all of us should build to. We're not saying it's ours either. We just had to do all the work to get to this point, right? What I think is really important is that we all agree to something at a data level. That's what a canonical does.
So Will, walking this back on a timeline from 2018 where you dissected the IGs, will those standards and subgroups change over time, or those standards set by the Da Vinci Group are really the core baseline that CMS looks after that you've driven forward, and you can expect those same subgroups and IGs for the next number of years or up to the next decade? I do want to learn a little bit more about how you're aggregating this scattered plan data for your health plan partners and for your carriers, maybe touching on some of their broken processes today.
Yeah, so a couple things, actually. The standards movement isn't going to change how health plan operations execute broadly. There are some key themes, though, that are coming through the standards that health plans have to adhere to, which then push into them a little bit if they haven't thought through this already. And that is, what's your single source of truth? So the principles behind that actually get deeply technical. I won't do that on this call. But if you have a data warehouse, as an example, and you feed that data warehouse, oftentimes health plans try to have that as their single source of truth. Now, they may not do that. They may kind of hybrid their single source of truth with other products within their company. But the data has to be accurate in order to populate these APIs that are required for CMS compliance, right? It's really important, though, to highlight that in 2018, value-based care concepts started to happen. Why we got excited, and why we raised our hand in the room day one of the Da Vinci Project in 2018 and said, listen, we'll help, is because we're third-party observers to this whole ecosystem. I didn't come from healthcare, actually. I fell into healthcare, and that's a whole nother discussion. But when you find big, ugly problems, by default, our business and the talent pool that we have at our companies likes to solve big, ugly problems. That's what we call them. And there is no bigger one, frankly, than understanding the complexity of the human body and its care journey through our ecosystem called healthcare in America, right? Big, big, ugly problem to solve. Just touching on that point a little bit more, the Da Vinci Project started a process for our country to actually start thinking about the details required in order for us to share data accurately. It hasn't finished that journey. That journey is going to go on for a while, right? Because you have the maturity curve of every company that has to commit to these CMS compliance objectives. Not only that, you've got new data coming, right? There's new information that's going to be necessary to communicate between providers and payers. Perhaps that's not known today, or perhaps it's still being fleshed out in these working groups. But the Da Vinci Project, as a general rule, I think it was a big turning point in America for us being able to data share.
Yeah, and that's a compelling story for any plan dealing with some of these challenges going forward. And this is a perfect segue into some of the other topics we wanted to get into. But in your typical engagement with a plan or with a partner organization, where do they see measurable gains first? Are we looking for implementation speed, audit readiness, or even a reduced integration cost? Because when I work with plans, and even from an issuer payer perspective, efficiencies can be realized both financially, so saving with hard dollars and bottom line dollars, or also non-financial efficiencies such as policies and procedures, like you said, actually implementing standard business processes around this for one single source of truth. You can put a value on that, but where are you seeing plans are measuring those first metrics?
Yeah, that's a really good question. From a pure cost savings perspective, there is the external reality that if they get an audit, that could affect their HEDIS scores, could affect their ability to get reimbursement for Medicare, right? That's one. That's an outlier, by the way, that hasn't fully been triggered by the government. They haven't said, listen, because you're not CMS compliant, we're going to ding you X number of dollars on this year's reimbursement. We haven't seen that yet. Now, it's inevitable, frankly, because and when I say it's inevitable, that downward pressure is pushing on the plans to execute. They have to execute. If they ignore them, most definitely they're going to get compliance dings, right? Our view is that the industry is maturing, and once it gets kind of slapped in the fanny, if you would, it's going to move a little quicker. And I've seen it already. We are getting some of our clients or new opportunities come in from states that are pushing on their plans about their compliance work. Interesting. Not coming from CMS, it's actually coming from the state. So that could be a variable that we see in the near future too.
Yeah, as state and federal enforcement, that'll definitely wake anybody up for sure. That's a great reminder to anybody tackling these in terms of an audit. This work is not the shiny crystal ball that everybody's following, but it's required work. Compliance work should always be funded within an organization as well.
One more point on that topic is the transition. I think it's 3 steps for health plans, right? The first step is to just check the box. Are they feeding an API endpoint, yes or no? Or have they invested in the pathway to feed that API endpoint as required? They have, good. Have they done it right is the next question, right? So that's the maturity curve. That's the next step. Data is really valuable, right? It's going to provide insights into everything that a health plan does and execute on. Not just a health plan, for patient. For patient, once they get that data, that's one of the underlying benefits, of course, of all of this, that the patient gets their data. So I think that value could be celebrated by health plans if they choose to embrace this.
I love that. And that actually brings us back to a member-focused or member-centric mission and thought leadership behind how every health plan should be operating, especially entering 26 with some of the challenges that we're facing or the headwinds of the industry. I guess this is another perfect segue for plans that are still heavily dependent on EDI. What's a realistic first step that they can take for setting up their first FHIR environment? What's that first push?
There's canonicals here. There's a canonical for FHIR as required by the CMS compliance regs. And there's a canonical for EDI. But it took 50 years for those canonicals to be created for EDI. You think we could leverage that a little bit? We could. I think we need to do a few things. First, EDI fundamentally is too strict. a data structure. It doesn't allow for flexibility, and flexibility to some degree is important when it comes to healthcare data exchange. But EDI traditionally is too strict. So FHIR is inevitably the pathway forward for an API economy like we have now. The meaning that is well documented in EDI constructs is the same meaning that could be applied in FHIR constructs. So what I'm saying there is source data could in fact be the same source data. Populating a FHIR server where you may or may not persist. Generally, most companies are persisting the data in the FHIR data store. Another alternative is a facade model where you're using the FHIR server. The concepts of storing the data in a FHIR format all should be leveraging similar source systems, is the point.
That's great for all the health plan executives listening out there too. When we talk about integrating with the health plan, Will, could you tell us a little bit more about your experience with procurement and how health plans could also modify or edit some of their contracts for their vendors or third-party organizations in terms of contracting or even standing up a process like this?
Interoperability starts at the contract. To be honest, it's not a technical challenge. It's more of an enterprise commitment to do X, Y, or Z when it comes to making that patient data available. Fundamentally, there isn't a single health plan I can think of or that we've worked with that doesn't have a wide array of operational systems. They have a claim system. They have a care management platform. They may have an EDI processing system. They probably do for any number of reasons. And that they have a lot of data that they're moving around internally. So they've made investments in software technology for years, right? They can't throw that away. But what they can do is they start thinking about how to normalize data as required to be shared. I could jump up and down and tell everybody that message, but here's the bottom line. If they don't do it, and they don't commit to that in the contract, where that company that they're relying on for compliance has to deliver for them. If they don't do that, then they're setting themselves up for less reimbursement, pure cash flow reasons, less reimbursement, but less forward thinking. And there are going to be advantages of capturing that audience of patients or members and doing things with those members that keeps them engaged with the health plan, especially as we get older. So those are all important variables that have to be considered for the executives.
Now, I think you've touched on a couple things here in terms of, I think another message to health plans and executives are dedicated resources, making sure you have the right technical or even product resources internal to your organization, including compliance, that it can actually help stand this process up. Number two, having the foresight and the actual, I guess you could say, being proactive instead of reactive. Understanding this process could take, a number of months to actually integrate through the procurement contracting process. I know personally that working with health plans, contracting is fairly slow. So starting now, when you're working on a plan year 2027 refiling or for next year, it's never too soon to get started. Will, we've covered a lot of ground today, and with all the rules coming out, looking out into next year, I do know that interoperability does have a close relationship to prior authorization and a number of other key items that should be at the very top of each health plan list. What are some key takeaways you could leave us and our health plan partners with?
You're spot on. The regs that are coming, the regs that are already required have their own kind of updates occurring. So one reg is due 1/1/26, has to do with US CDI, which is a construct within all of the different FHIR payloads. That got notably modified, and that, believe it or not, that's for plans that have started the 9115 journey. It's our understanding that many have not even started the 9115 journey because they haven't felt pushback. There hasn't been reinforcement per se. Now, next year, what's ahead of the second wave of the 9115 regs, which is patient access API, the next wave is 0057F, which is getting all the dialogue in the industry going. There's lots of active dialogue going on here. And this is all around prior authorization. So the concept that, we can request a prior auth or required to do a prior auth based on a plan's design, so on. And the provider knows exactly what to do in order to execute on that prior auth. And what if it gets denied? And that whole feedback loop for prior auth is considered one of the more complex workflows that's going to be needing to be fleshed out over the coming years. 1/1/27 is the date to which the digitized workflow is to be in place for prior authorization. And there's a lot of work that has to happen for that because all the rules that are buried inside these health plans about what is and isn't prior authorized is not easily gotten. And worse yet, it's not easily explained when there's a denial. So because it's not easily explained, because there's a denial, and there's many systems out there for the concept of care management, what is the rules to handle a given population within the plan as it was defined, that's a lot of complexity. So it's really ripping at the operational efficiency of a health plan. And these CMS regs are going to be enforced. It's inevitable. And there's going to be a maturity curve for prior authorization too. Health plans that haven't thought through this are going to be in a world of hurt coming up here in the coming months. And that's not me spreading fear, uncertainty, and doubt. That's not me doing that at all. That's the industry. And all the health plans that we interoperate with today all have something on their roadmaps with prior authorization work. It starts with the discovery because all of the internal systems are often uniquely configured. So that discovery starts to identify how we're going to get rules out of the claim system, how the care management system interacts with the claim system. That's called the utilization management platform. All of that complexity has to be objectified. You have to be able to see it and draw conclusions based on the nature of how those systems have grown together within a health plan before you can create a design pattern that'll fix it. Those design patterns are what our strengths are. I mean, that's just how we see things. Everybody should have some insights into how their systems operate. Oftentimes, that's not the case. So when you start lifting the covers and you start seeing things that require business engagement, that's where things slow a little bit, and they should slow because there's new things being learned about how they've behaved all these years, right? So 0057 is going to do one important thing really well. I suspect it will lower the number of prior authorizations because health plans will just say, for this class of prior authorizations, we're going to automate those. We're not going to adjudicate them. For those that are more complex, where there's adjudication required for a prior authorization, and there's a determination that that prior auth is going to be denied, they have to be able to automate an electronic response. Now think about that. It's not easy, right? It's a very complex workflow. As we work with our customers, we envision this as being the biggest process challenge that our health plan clients have. But this is way before the technology happens, right? Technology is only going to be enabling when we understand the workflow that has to be enabled.
Wow, I think the message is clear, and you're speaking not just to one particular type of health plan, but net new issuers entering any marketplace or product type for any time, renewal issuers, regional players, hospital health plans, even some of the fortune plans having a plan in place. It seems like TESCHGlobal is not just working 6 months, 1 year ahead of time, but 2 to 3 years ahead of the curve to get ahead of the ball. So thank you for sharing your subject matter expertise. I think as we wrap up, it's going to be important to know where our health plans and executives can find you. Tell us where we can find TESCHGlobal, HealthLX, and Coco.
So the software, we're going to be open sourcing through an Apache open source license. Stay tuned. You can go to cocodata.org to get details on that. That's a website dedicated to that. It's what we're donating to the ecosystem, and it's a framework for how the data should be organized and handed off to anybody that's doing the mapping work. That's a target canonical. That's what that is. HealthLX is the software platform that we put all of this in a turnkey solution for health plans that need to be compliant. They can contact us and we can make that happen. And then TESCHGlobal is my brilliant team of engineers that helps people through all the nuances of what should be easy today, but is not. You can go to TESCHGlobal.com or HealthLX.com to see more on each of those companies.
Well, thank you and for your whole team for all your help and support to the industry. And thanks everybody for listening in to another great episode. Give us a like, give us a share, and we'll see you all next time.